begin. Right, so see, on our exam day, we're going to have around 16 stations. Out of those 16 stations, some of the stations would be on history taken. They're going to be 2 or 3 structures that we need to work for. The first structure is medicine structure, right? Like, for example, the patient comes in with some complaint, right? There are 2 or 3 kinds of complaint a person can come up with, right? 3 complaints a person can come up with. The first complaint the person can come up is with pain, right? That's the first complaint. The first complaint a person can come up with is pain, right? The second complaint a person can come up is with discharge, right? The third complaint could be any other, right? Any other. So there is main pain, discharge, and other. For pain, we're going to use Socrates, that we're going to talk about in a bit. And for discharge, we're going to use Trek, that we'll also be talking about. For any other complaint, we're going to use Odipara, right? Odipara. So let's just do this. Obviously, when a person comes in, you are the junior doctor, you're dealing with a patient, right? You are a junior doctor, you're not a senior. Even if you're working as a consultant in many of your, if we are working as a consultant or a resident in our setups at the moment, we have to act like a junior doctor, meaning we always have to pretend like we know things, but not to the extent of that we can cure them or can definitely treat them. We're just there to stabilize the patient, right, on their initial complaint, right? So there are 3 or 4 settings where we would be, having these patients. The first setting could be the GP clinic, right? It could be the GP clinic. The second setting is an accident emergency department, right? The third one is psychiatry. Then there is cardiac, right? And then there is Wellman clinic, right? These are the 3 kinds of settings that we have on our exam day. All right. So when we begin, we're going to get 30 seconds. We're going to have 30 seconds to, read the scenario which is outside, right? Read the scenario which is outside the cubicle. We're going to get around half a minute. So we have to read this scenario. After we're done with that, we always have to capture the name at the very end of it. When we get inside, if the person that you're looking at, that's the beginning, right? As soon as you enter, that's the beginning of your consultation, right? Your consultation just begins. And what you have to do is, if the person doesn't seem agitated, if the person doesn't seem in obvious distress, the first thing for us to do is smile, right? That just begins. This is the starting of our IPS, where the rapport building starts, right? Smile. That's the first thing, smile. Then you need to introduce yourself by telling your name and your occupancy there, meaning where you are, accident emergency, or the GP, right? Then you need to confirm the patient's name. Always, in every type of situation, you need to confirm the patient's name and their date of birth, not their age, their date of birth. Yeah, you can do the age, but date of birth seems more appropriate, because that's how they do it there. So date of birth is something that we'd be doing. And as soon as we started to talk, we introduced ourselves, right? So then we have to ask them, what brings them here, right? What brought them here? If, there are 2 ways to begin. Either we could say what brought you here, or what we could say is that, like we just notice what the person's going through. We just notice what the person's going through, and we could just, observe and reflect on that. So acknowledge, right? Acknowledge their situation, and then reflect on that. What do we reflect on? We're reflecting on what the patient is feeling. Maybe they're, crying, maybe they're angry, maybe they're fidgety, they're tapping their hands, they're tapping their feet, maybe they are, in obvious pain. So if they are not acting as a dramatic actor or a patient, we should be beginning by asking, what brought you here today, right? If it's not the case, and we can see that they're dramatizing it, we have to acknowledge that. We can say, I can see that you're in obvious distress. I can see that you're, a little fidgety. I can see that you're fumbling a little, and things like that. We need to acknowledge that. That's the beginning of our 4 marks, right? IPS, interpersonal skills. That's where it starts. So we could just acknowledge that and then move forward and say, what brought you here? Then after we've done that, after the introduction, as you know, we've always been working, right? So, or even when you were writing your OET letters, right, you always start with presenting complaint. You start by that. What brought you here, right? When you say what brought you here, the patient tells you I have pain. Ask them, can you elaborate that pain? Can you talk a little bit more about it, right? Like, just don't stop there. Just don't stop there. You need to make sure that the patient talks before you want them like say something, right, before you start questioning. Make it open-ended, and make the patient talk. Make the patient talk always. If you want to get marks in your PLAB2, make the patient talk, right? Make the patient talk. You asking many questions, you're not going to get marks. You have to be sensitive, you have to be specific when you question, right? So first, open-ended questions. For example, a patient comes in and they say they've got pain in their tummy. You say, all right, can you tell me a little bit more about it? So the patient goes like, all right, doctor, I've got pain in my tummy and it's been there for around a week. And the patient says, it gets worse when I'm eating, and it doesn't really work out. So, like he's told you 3 or 4 complaints. After they've told you 3 or 4 complaints, it's your job to elaborate it via using Socrates, right? Via using Socrates. That's how you'd elaborate it, right? So first you would be asking them about their complaint, right? Always start with open-ended questions, right? Then you could elaborate it via Socrates, right? You can use Socrates. What is Socrates? It is, you've been doing it: site, onset, character, radiation, associated symptoms, time, exacerbating factors, and scale, pain scale. Never forget that. Now, if this was an emergency, you'd want to do that, right? If this was an emergency, you'd want to do that. Never skip on the pain scale, because that'll just tell you and give you the diagnosis, right? They'll definitely just, jump you to the diagnosis, a part of it, right? So start with Socrates, then you move forward, and or if the patient's got any other complaint, right? Apart from pain, if they've got any other complaint, for example, they have shortness of breath. If they have shortness of breath, then the mnemonic for that is Oripara, right? Oripara, which is onset, right? Onset, then duration, then intensity. Like, how intense is the cough? Is it getting worse, right? Is it getting intense, right? How is the intensity of it? Like, do you feel like, like the intensity, we've got four grades of dyspnea, so we could just assess it on that, right? What is the progression of it? What aggravates it? What relieves it? Is there anything associated with it, right? Then your third thing is track, right? Which is for discharge, like time, or when does the discharge happen? If it's from the mouth, right? Bleeding, that's a discharge. Vomiting, it's a discharge, right? Ear discharge. Okay, so time, relation to the presenting complaint, right? Relation, is it related to something? Amount of it, character of it. After you're done with your presenting complaint, and if the person, if he came for pain, and then you told them, is there anything else, right? Then that becomes your presenting complaint too. Then you have to use these mnemonics and explore that presenting complaint, right? So you need to keep on exploring until and unless when the patient says, this is it, there is nothing else. Then you move to the next thing, where you still ask them that, is there anything that you're really worried about today? But you'd only do this main concern thing when you are in non-emergency setup, right? Because after you're done with your presenting complaint, you definitely are almost sure about what this person has, right? Because this is your clue to, for example, the patient comes in and he says that he's got a pain in his chest, and he's got pain in his, and the pain radiates to the jaw, or the pain radiates to the left shoulder. You're thinking ACS, right? You're thinking MI. So your presenting complaint definitely just tells you what the diagnosis is, right? What the diagnosis is. And if the patient has an MI, that's an emergency situation, and you tell them that, what's your main worry? Now you can do that, right? Definitely ICE is important. But if you do that in an emergency situation where things are really obvious, you're putting the person in distress, because in an MI, the person's going to have a pain on the pain scale around 8 or a 10. Right? 8, 10, 9, right? Like, it's really, really severe. Do not annoy the patient. Do not bore them, right? So really important that you make sure that, you're not boring them, and that you're asking relevant questions, right? You're asking relevant questions, right? Okay, then, or if it's a non-emergency situation, then we can say, all right, so you told me you have this and this. Can you tell me what is exactly that worries you the most? Then they'll tell you that, I'm worried. If they came, for example, with pericarditis, right? They're coming in the GP clinic, they came with pericarditis, right? Then they can tell you that, I'm worried about that, it might be MI. And then you would ask them, why do you think it's an MI, right? And if the patient says, I think it's an MI because my parent has it, or somebody else had it, or I saw it on the interview, interview or in the TV, or my friend had it. So, then you can explore it more, right? Now you have to ask differentials. Now, after you're done with the presenting complaint, you think it's an MI, and the person told, I think that this is because my father had it, I might have it too. Then you need to do differentials, at least 4 differentials, right? So chest pain, 4 differentials. I mean, you're going to include things that could kill the patient, right? For example, pulmonary embolism, for example, heart failure, for example, an MI, for example, like your aortic aneurysm, right? So those things are the ones that could kill the patient, right? Then once you have reached the diagnosis, because once you're done with the DD, once you're done with presenting complaint, you have at the back of your head a diagnosis. Once you've made a diagnosis, make sure you ask them about, if there is a risk factor associated with their diagnosis, right? For example, the patient has stroke, right? The patient has stroke. If the patient has stroke, the risk factors for stroke are what, right? He must have got some diabetes mellitus, maybe hypertension, right? Maybe have family history, right? Maybe she's taken venous thromboembolics, right? She could have a venous thromboembolism because she's taken COCP. So you need to ask the risk factors associated with the diagnosis that you've made, right? And also, you'd also be asking questions regarding complications, right? Like if it is an MI, right? Or if it is an heart failure, or she had an MI earlier, the MI's complication could be a heart failure, ventricular fibrillation. So you need to ask them questions regarding that, are you having any fluttery feeling in your heart? Are you having any shortness of breath? Is there any, edema on your feet? So you're trying to explore the complications too, as you're going towards the diagnosis. You made a diagnosis, a provisional diagnosis in your head, and you're trying to exclude the other things too, right? After that, when you've done the relevant history, you come to the past history, which is very, very important, right? So presenting complaint of this condition, right? Now we have to ask the basics. The basics are heart failure, hypertension, any arrhythmias, any thyroid, stroke, cholesterol, which could be related to the condition, right? Also surgical problems, right? If there is nothing, first you need to ask them, like they brought always, always start with the open question. Every time you're going to do history and you move to, like for example, you start the presenting complaint, you come into the history of presenting complaint, right? Always start with an open question. Now you come into the past medical history, open question. Do you have any condition? Do you have any past medical history? Or do you have any prior condition that you're diagnosed with, right? Are you taking any medication for it? If they say no, move along. Do not waste your time. Do not ask them, do you have any diabetes? Definitely, if somebody has diabetes, they're going to remember it. Do not waste your time there, right? Just move along. Next thing comes your lifestyle. Lifestyle would be your exercise, your diet, your alcohol, your smoking, right? Here you can signpost. You can say, I'm going to ask you some questions regarding your lifestyle. Do not say I'm going to ask you personal questions. Asking about smoking and diet and alcohol is not personal, because you are the doctor. You have the right to ask these questions, right? This is not personal, right? That's all right. But if you're going to ask them about the intimate life, right? For example, if you're asking about relationship with the parent, you're asking about a relationship with a friend, then definitely, you need to ask them that, I'm going to ask some questions, and we do ask these questions so that we could help you. Is it all right if I ask, right? If I ask some questions regarding your relationship with your father, right? So you need to signpost when things get intimate. When you're asking about their sexual history, right? Sexual history is intimate. So for sexual history, you'd definitely be asking them questions regarding it, and you would definitely be signposting. Otherwise you don't need to signpost. Also in like you can do signpost in a lifestyle, right? So also in IV drug abuse, please signpost. Then if you're dealing with a young female, right, you always need to exclude the 4 things, right? Pregnancy, always ask them, no matter the station, please do ask them. It's going to give a good impression that, if the person's taken any pills, if the person's periods are fine, right? If they're regular, if there is a discharge in between, if there is any irregular bleeding in between, if they're up to date with the pap smear, if they're pregnant, right? This is important if you have a young female, all right? Then comes your further history, right? Where you start by asking about 3 important things from the patient. Number 1, medication. Yes, we did ask them if you are taking any medication for your, for the conditions that you're diagnosed with. For example, they're diagnosed with diabetes mellitus and they're taking insulin. right? So definitely they're taking one medication there. We need to ask again, after we're done with the past medical history, after we're done with the family history, we need to ask again, are you taking any medication apart from the medication that you mentioned? Right? Simple sentence, apart from the medication that you mentioned, right? That's really important, because sometimes they do forget. Then they'll tell you, I'm taking some some herbal medication, or some herbal tea, or I am I am taking some multivitamins. That's important at times, but you need to figure out when to ask this, right? They clearly have said, we were discussing earlier, the errors that a person does in PLAB2. So we need to definitely discuss the things which are relevant, right? Always ask things which are relevant, right? Do not ask irrelevant questions. How, you see, they have told us that we are supposed to end the station in 8 minutes, right? That means in 4 minutes we're supposed to do what? We're supposed to do the history, we're supposed to do the labs, we're supposed to do the examination, we're supposed to come with a professional diagnosis, right? We're supposed to do these things, right? Because they're not stupid. They gave us 8 minutes because they think that as a junior doctor, we can definitely talk about the medication, we can definitely tell them what the allergy, we can do all of it, right? So we're supposed to do this within 4 minutes. Okay, so after you've asked them about medication, the next thing you do is ask if they're allergic, right? But then again, in emergency situations, try not to do this, right? Even though it's important, but you have to weigh your odds, right? Where you're going to ask this question. So you might want to ask this question when the things are not emergency, right? Though sometimes in emergency, it's important if you're giving them an anaphylactic, like anaphylactic shock for something, then you definitely need to ask them. If you're giving them an antibiotic, that's where you're supposed to ask them for an allergy. If you're giving them a painkiller, do ask them about an allergy, but you have to understand where to ask it. Then family history regarding the condition that they're having, right? You're not going to ask if a person is a male and he's got prostate cancer. You're not going to ask them if there is anyone in your family who's got breast cancer, right? That's stupid. So ask relevant questions, right? In history, there are three things that are really, really important. Number one, always exclude the things which are going to kill the patient, right? Always exclude the things that are going to kill the patient. Number two, always do eyes. Always, right? This is going to help you. This is going to help you in non-emergency situations, though there are some emergency situations where you're going to ask them about eyes, which is idea, right? Concern, and expectation. Now, where to do what? Right? Where are you going to ask this? When you're going to ask about idea, you should probably ask them right before you give them a provisional diagnosis, right before you're going to give them provisional diagnosis. Concern, when you're done with the presenting complaint. Expectation, when you're going to start the management, right? It makes sense, right? Because if a person's come up to you and you're going to manage them, you need to ask them why, is there anything in particular that you want us to do today? Then the patient will be like, I'm thinking that I've got an MI, please let me get through with a cardiologist, or I want to get an ECG, right? So do ask them if there is anything that they expect, right? If they have something in the back of their head. Yes, not always you're going to do that. That seems stupid, but at times when you feel like the patient needs it, definitely supposed to be done, right? Then the red flags. For red flags, you're going to ask about maybe if they're having any swelling, right? Like red flags, like any cancers, any things that are going to kill them immediately. So you could ask about fever, right? When you're trying to exclude the things which are dangerous. Fever, swelling, loss of appetite, right? Because these are the main things when you're trying to exclude your the killers. Okay, then you are supposed to ask psychosocial history, right? When you're doing history questions, please do ask psychosocial history. Psychosocial history meaning that you're going to ask them that is there okay, psychosocial meaning, who do you live with, right? Number one, who do you live with? Is this condition affecting your mood? Is this condition affecting your mood? If this condition is affecting your mood, it's going to affect the people around you. If the people around you are affected, then you in turn are affected as well, right? So see if this condition is affecting your lifestyle. Is it affecting your work? Is it stressful? Do ask them this question, because we're doctors. They're just trying to see if as a junior doctor with three things. Number one, what they want us to do, because we've done PLAB1, right? So in PLAB1 they assess their knowledge. Everybody's going to say that you guys know it, right? The next thing they want to see is if we are a safe doctor, right? If we are a safe doctor, if we are an empathetic doctor, right? If we're an empathetic doctor, if we are a good doctor, right? What does that mean? Safe doctor meaning you exclude the things that will kill him, right? Exclude the things that will kill him. Empathetic meaning you understand their emotions and you reply accordingly. You reply accordingly. You give them the comfort, right? You give them a comfort. Good doctor meaning that you are having knowledge of the thing that he has, right? So that's what we're supposed to do. So medication, allergy, family history, travel history, occupation, social history. Then at the end, we're always going to end with, again, an open question. Is there anything else you want to add to what we've already done, right? So this is really, really important. Okay, and absolutely important to be asking about the psychosocial thingy, in the in chronic conditions, right? Then at the end, before we are going to manage them, please ask about the expectation. All right, next thing comes your examination at 4 minutes. At 4 minutes, please definitely be done with your history taken, right? At 1 minute, try and do the examination, because you know the examination is going to be just you verbalizing the thing, right? So you're going to say first, always consent, always consent, always consent, always, never forget consent. You're going to say, like, thank you so much for answering my questions. Now I want to progress and I would like to ask some questions. Now I would want to examine you, right? I would want to examine you so that I can see what is happening, right? So that I can see what is happening with you, so that I can understand that everything that we're doing right now is, going to be relevant to what we want to do, right? So always ask relevant questions, right? Always ask relevant questions, right? Relevant questions and relevant examination, right? So you're going to say that, I would want to examine you first. Whenever you start examination, right, start with observations, right? Like you're going to ask them, that I'm going to check your vitals, right? I'm going to check your pulse. Always start with that, because that's pretty obvious, right? That's pretty standard. You start with pulse, you do the blood pressure, then what do? Then you check the temperature, maybe if the person's got fever, right? Temperature, right? Temperature, oxygen saturation level, pulse, okay, whatever the main things are in the observation. Then you'd be doing your systemic examination related to the person's system that he's come with, right? Chest complaint, chest examination, right? Not the back examination. Abdominal complaint, abdominal examination. Then you have to verbalize, right? You always have to verbalize, unless they definitely saying outside in the scenario that explain the examination to the examiner. Do not talk to the examiner, right? Do not talk to the examiner. If the examiner tells you, and like, you don't have to wait and ask them that if there is any observation, right? Okay, like for example, you check their vitals and the examiner is saying nothing, that means everything is fine, right? Everything is fine. And please remember, if the person's got an MI, right? If the person's got an MI and you think that, you need an ECG, right? You had at the back of your head, you need an ECG, and you are an accident emergency, first of all, right? You need an ECG, you need the cardiac markers, you need the cardiac markers. But if you do not verbalize that, the examiner is not going to tell you the results. You understand what I'm trying to say? I'm trying to say here that if you do not ask them, if you do not tell them that, like you're talking to the patient and his name is Mark, and you're saying, Mark, and along with that, I would also want to, send blood results for your cardiac markers. I would also be running an ECG test, which is going to trace your heart. If you don't say that, if you don't verbalize that, if the examiner has the results, he's not going to tell you that, right? He's not going to tell you that because you didn't verbalize it. Because you didn't verbalize it. If you don't verbalize it, you don't get it. So it's really important that you understand this, right? Okay. Then, right, then after we're done with examination, the next thing, which is still your data gathering, is forming a differential diagnosis. We've got 12 marks. We've got 12 marks, right? 4 marks for IPS, which started as soon as you entered, as soon as you talk, as soon as you started interacting with the patient. 4 marks for IPS, that started. Now 4 marks for history taken, that we just did, examination, that we just did, right? Then it's also going to be your labs, right? Then forming a differential diagnosis in your head, right? And when you're going to start management, that is when you're going to talk about the differential diagnosis, how you're going to treat it. That's when the other 4 marks start, right? The last 4 marks start. Okay. So when you explain a differential diagnosis, there are two ways to it. For example, the patient's got an MI, right? The patient's got an MI, the patient's got an MI, and you explain a differential diagnosis, right? So you could say, thank you so much for answering my questions based on what you've told me and what I've seen, what you're suffering from. First of all, don't use the word suffering, right? Do not make them suffer. They're already suffering, right? So you'd be saying, based on what you've told me and the examination and the history that I did, I feel, or I believe, right? Or I believe, right? Not we, I believe that what you're having or what you have is an MI, right? Then you'd ask them, have you ever heard about it? Which is very, laid back and, a very lazy kind of way of asking that, do you want me to explain it or you know it, right? Do you want me to talk? Because I don't feel like talking, right? That's another way. That's like you're lazy and you don't want to, just be interactive. However, there's another way. There's another way. And the other way is that, you tell them that, based on what you told me, Mark, sometimes what happens is that, your heart, which is getting a supply to itself for via its own blood vessels, the blood vessels get blocked. And because of that, the heart does not get the oxygen or the nutrients it needs. And as a result of that, the heart muscle dies. You're going to make it very simple. I know I'm making it hard. You're going to make it very simple. And then you're going to say that, that can result in a condition which is called heart attack. And this is why you experience the things that you experience. That's why you had this chest pain. That's why you had the shortness of breath, right? That's why you had the pain in the arm, right? And I'm suspecting that you might have this, right? Then just ask them, do you understand what I said? Or I hope this is making sense, right? Like end it with a question, right? When you do that, the patient can, ask, then you can ask them that, are you clear? Are we clear? Have you heard about that? Right? Then you can say, no, I did not. Right? Like what I'm trying to say here is that don't wait for them to ask. It's your job to tell them, right? There is this other way you can do that. Definitely try and do that. If it works out, if your time management works in that, go for it. If not, please start by explaining. Please start by explaining the diagnosis in simple words. In simple words, simpler, very, very simple, right? Like when you were learning MI in your Montessori classes, right? When you were learning MI or heart attack, Montessori, by Montessori, I mean first year. Montessori was first year medicine, right? That was our Montessori. Right now we're doing what? Maybe we're in grade 10th, right? Because, we're progressing further. When we do our residency, that's when we would have, been somewhere in the top in the medicine fields. And, it's a long journey. What I'm trying to say here is be simple. Be simple, and do not at the back of your head, when you are inside the cubicle, do not at the back of your head, have a thin preformed. What I mean by that is, do not think what the person might have until and unless you're done with the history. Until and unless you're done with the history, please do not have something at the back of your head. It's really, really important to be four things now, right? Being a good doctor, being a safe doctor. What else was there? Being a good doctor, being a safe doctor, and being an empathetic doctor, and having a fresh mind. Having a fresh mind, right? Meaning you're open to anything, right? Open to anything. For example, the person has an MI, but his main complaint is not the MI. His main complaint is because his partner is abusive, right? That's why he came. So you need to be very careful that why you're dealing with this patient, right? What is the reason that they've come today? They had an MI 2 days ago, fine, all right, that's not their major complaint. Why did they come today? That's a problem. Because right now, I guess that in PLAB2, they're given scenarios which are very, very open. They don't tell you exactly what's wrong. They'll just say, the patient's got some concern, talk to him. That's it. That's it. And you need to explore it. So you have to be, like really, really sharp. You have to be very, very observant of what is happening. Listen to the patient always. Active listening is so important, right? So you're going to explain them the diagnosis. You're going to, how, then there's another way of explaining the diagnosis. You're going to say that, instead of saying based on what you told me, how about you say, Mark, I've examined you. Thank you so much for that. You told me that, you had a chest pain that radiated to the arm. And I've checked your ECG, the heart tracing. There are some problems in that. And it shows that, you know, the blood supply to the heart has decreased. And when that happens, you experience these symptoms. The condition that causes these symptoms is called heart attack. And I suspect that you haven't this. Have you ever heard of it before? Right? There's a way to everything. You can simplify it, right? How can you simplify? By saying that, you know, the symptoms that you told me in the history or the things that I observed in the examination, those both combined tell me what you are having right now, right? What is a provisional diagnosis? What are the differential diagnosis, right? So right here, talk about the history, talk about the, you know, examination, explain them condition, then talk about the term. So this is the basics of how you're going to take history when it comes to the medicine scenario. Now comes the management, right? Now comes the management. Management is also really important, right? Because you're going to get four marks, right? Now, in management, you see, in the UK or in any other country, and even in the countries that you're working in, you can never force a person to do something. That's number one, right? So forget the following words. Forget the following words when you're talking to the patient. When you're talking to the patient, forget the following words: should, need, want, have. What do I mean? What do I mean? This is actually from the things that I've learned from Dr. Mo, Aspire, and Samson. This is not from me, because obviously we're learning from one another, and they've learned from their teachers. So, you know, we should give credit where it's due, right? We should give credit where it's due, right? I'm also learning at the moment, right? So do not say these words: should, need, want, have. Don't say that, right? Like, you are not going to say, I think you should lose weight, right? I think you should lose weight. What's a better way of saying it? I think there are some ways we can help you through which you can lose weight. You see what I said? I removed the should, right? Because, you know, when you go to a friend and you tell them that, you know, like, you've gained weight, and they tell you that, you know what, you should lose weight, there is no difference between that friend who is just giving you an advice. You know, there is one thing: advice is good when it's asked for. Do understand that. This is like, you know, the basic principle of life as well, right? Advice is good when it is asked for. If somebody doesn't ask for your advice, don't give it to them. All right. This is a side note, right? If somebody doesn't ask for your advice, don't give them. So here, the patient just came with the complaint. They didn't want your advice, right? They don't want your advice. They're not here for your advice. They're here for you to treat them, right? So even though it's our job to advise them, we're not going to talk to them in a way that would force them, right? We're going to use words which are simple, which are more friendly than a friend's talk, right? What do I mean by that? By that, I mean that, you know, if you want someone to stop smoking, don't say, I think because you had an MI, you need to stop smoking. How about you say that Mark or John or Elise or Kesha or whatever their name is, or Mr. Stanley, I feel that, you know, you have MI, and, you know, there are certain things that we can do to prevent a further or a future episode of it. There are certain things that we cannot control, but there are certain things that we can control. And one of the things that we can control is smoking. How about we discuss a way through which we can help you in quitting smoking, right? You see the words that I use: help you, right? Help you. Explain them why you want them to quit smoking. Give them a reason. You know, when you read the errors file, which is given by GMC, there they say, do not force them, right? That's number one. Secondly, tell them the reason why you're doing it, right? And also Einstein said that a person who is a good explainer, or a person who can explain better, is a person who knows the thing well, right? If you don't know the thing well, you can never explain it well, right? So if you understand why you're asking them the question, then definitely you can give them the reason that you are asking them to do this. Why? Right? So always give them the reason. Right? Now, if you know, you want someone to be, you know, taking their medicine on time, right? So you can't say that I want you to, you know, take your medicine on time. You can say that, you know, you've experienced, for example, there's a person who's got asthma, right? And they're not taking their inhaler as prescribed, right? You can say that now there is one way. One way is to tell them that, you know, I need you to take your medication on time, right? The other way is that, because you've experienced these symptoms and you had to come to the hospital and it was very difficult for you, you had your shortness of breath, and I know that this is something that you didn't want, and I too want you the best for you. This is why I feel like that we can help you in organizing a way, or we can help you by arranging a person, or you can relay this information about your dosage or time of your medication to a friend or to your daughter or anyone who's around, so that they can administer or help you remember when to take the medication, right? I know just one can, just one sentence want, I want you to take it on time. This is very simple, very easy, but that way the patient doesn't understand, right? If you read the GMC errors file, right, we've done this earlier, there they definitely say that, explain to them the thing, right? They don't explain, they say that have a reason of why you're doing things, right? So when you know why you're doing it, you can also tell them why you're doing it, right? Okay, so that's number one. This is optional. The advice cannot be forced. Don't use the words want, should, have, need. Don't use them, right? Okay, then you can, like you can also signpost your management plan. You're going to say, all right, so since we've done this and you know what your complaint is, how about we are going to explain to you the way through which we can manage it, right? So we're going to discuss within the management plan, right? Right, I apologize. Okay, so we are supposed to make sure that we explain them, right? So we're going to say that this is a management plan, and you have to plan it. You have to give them a plan, right? That this is what we can do, this is what we can do. We're going to talk about it. Always take consent when you are telling them the management. Do not force on them, take management. And also it's going to be a two-way conversation. It's supposed to be a two-way conversation, right? So what do we do? How do we make it a two-way conversation, right? So it's going to be a two-way conversation, right? So first thing, there are 7 steps to this. This is via Dr. Mo, right? There are 7 steps to this. The first one, you're going to admit it. You're going to admit the patient, right? You're going to admit the patient, right? Admit the patient, refer them to a senior, right? Like you're going to say that I'm going to talk to a senior. Either you admit them if they're in the accident emergency. If they're in the GP clinic, you're going to refer them. If they're going home, do not talk about it, right? Then there are investigations like blood, urine, stool, imaging, right? Then there is symptomatic treatment, lifestyle management, right? We talked about it, right? The symptomatic treatment would include oxygen, fluids, painkillers, antibiotics, right? And lifestyle management includes the things that he has, right? If he's smoking, you're going to talk about it, right? Okay, then the fifth thing is you're going to send them to the specialist. Then you're going to ask them for his follow-up if needed, right? However, do not tell them when, because in the UK they don't do that. And safety net. How do you safety net, and what are you safety netting for? You're safety netting for 2 things. Number one, what they came with, that if you have this condition again, please contact us. And the second thing is that the complications for this, right? So that is your structure for history taken. Then come into the structure for test results. Now in test results and in counseling stations, the person's already been diagnosed with things, right? They've already been diagnosed with things. They've come to you for the results of it. So you have to always introduce, you have to always greet. Then you have to take a modified simple history, which includes why they took this test results for, why they're here today, right? What could happen in the future. So you're going to take the relevant history according to that. I'm going really, really briefly because this is something that we'd be doing inshallah when we practice, right? So then explaining the results of the diagnosis and then managing them. Again, the same thing, right? But you have to again do the consent, give the reason why you're managing them, have a two-way conversation, and always address the patient's concern, and then go for medical treatment when it comes to test results. When it comes to the counseling structure, again, the patient's been diagnosed. You again have to take a relevant history about his past condition, his present condition, like the risk factors that he has right now, the complication that could be in the future. Then explain to them what they had right now, right? And why did they have it, right? Okay, and then we're going to do management, where we're going to advise them, where we're going to talk about the risk factors, where we're going to do the medication, involve a multidisciplinary team, and then go for safety net, right? Always have a two-way conversation. And this is it about these structures, right? And I think that I'm going to end it right now. And inshallah, tonight we are going to, do practice on the respiratory stations.